Okay, the last topic on this chapter is macrosomia. Macro being big, soma being baby. Definition of macrosomia: fetus with estimated fetal weight 90 to 95 percentile for gestational age, with a birth weight of 4 to 4,500 grams. There is no clear agreement on what should be the parameters, but 4,000 to 4,500 grams. Unfortunately, ultrasound accuracy in predicting estimated weight is not good. The errors in prediction are up to 400 grams, which is almost a pound either way. The risk factors for big babies: glucose intolerance, GDM over diabetes, prolonged gestation, going 42 weeks plus. Big mamas, high BMI, tend to have big babies. High pregnancy weight gain. So if you have a big mama who gains lots of weight, goes post-term and is diabetic, you can expect a big, big baby. Women who are multiparous, and male fetuses tend to be bigger than female. What are the hazards? There are hazards to the mom, to the fetus, to the neonate. Maternal hazards: operative vaginal delivery, she can't push the baby out. Perineal lacerations because of shoulder dystocia. Postpartum hemorrhage from an overdistended uterus. Cesarean section delivery. Pelvic floor injury. And who knows down the road, urinary incontinence, pelvic prolapse. Fetal hazards: shoulder dystocia, birth injury, Erb's palsy, asphyxia, if it's a prolonged delivery. And neonatal hazards: there's clearly increased admission to the intensive care nursery. Hypoglycemia is very common, and nerve injury. Fortunately, most of these nerve injuries are transitory. Prevention. The challenge is there is no good, accurate way of predicting or prevention of macrosomia. What folks have suggested is do an elective cesarean if the estimated fetal weight is over 4,500 grams in a diabetic mom or over 5,000 grams in a non-diabetic mom. But I've done this on estimated fetal weight of 4,500 grams, and the baby turns out to be 3,500 grams. And then you say, did I need to do it? Early induction of labor. But here you're concerned if you have an unfavorable cervix, you may have a failed induction and then have a cesarean anyway, an emergency cesarean. So it's problematic. Macrosomia, we really don't understand well, we can't prevent it, and we're really not sure how to manage it. This picture shows a macrosomic baby of a gestational diabetic mom. 14-pound, 8-ounce Supertonio, big baby. Here's a 17-pounder from Brazil, the giant. Shoulder dystocia clearly is a function of birth weight, and yet we're not very good at predicting birth weight. This is the problem with shoulder dystocia. This looks at how accurate we are in predicting birth weight. Clinical, ultrasound, just ask the mother what she thinks. Not a whole lot of difference. Macrosomia. And that's the end of this section.